all my AI talk requires some kind of fancy stuff. Want to make sure, do we have the mouse that is working? Right? How do we highlight? No, this is theirs. Or maybe this one, yeah. Okay, I guess we need Sophia to come and fix here, right? Nothing is. Hmm? Hmm? No, we tried earlier, right? Oh, there. I think we found it. No, it's not moving well. Yeah. So, good morning, everybody, and thank you, Beth, for the introduction. So, important two things I'll be discussing. One will be the yellow studies, that which I am very proud of, that which Sinai itself done, and what are the new things that we are doing here in Mount Sinai related to the AI work, and I'll be discussing one of the project that we did along with the nursing, which is Sophia. So going to the yellow studies, we have been working on something called as how can we take care of the coronary lesions, and how do we understand how to prevent the progress of these lesions. And yellow, we have 3 yellow series and more to come. We started this about 15 years ago. So in yellow one, what we did was we took patients who had coronary artery disease and they had obstructive lesion. When we say obstructive lesion, the fractional flow reserve physiology was significant. The essential question was, how can this progression of lesion can be prevented by giving just medications? What we did was we took the patients, they had to have significant FFR, which means it was an obstructive lesion, then randomized the patient to standard of care or what high dose statin, which was rosuvastatin, which was just coming into the market at that time. We used the treatment only for 6 to 8 weeks, which was one of the largest criticism, that your plaque change cannot happen in 6 to 8 weeks because the plaque that is built in your body takes years, so it's not going to change in 6 to 8 weeks. Despite that, we did see the so-called LCBI, or the yellow that you're seeing, which is intravascular imaging, decreased when they came back in 6 to 8 weeks. The IVUS did not change, FFR did not change because it will take a longer time. Having done that, then we went to yellow 2. So we know the plaque changes, but how does this plaque change? So one of them, which we understand, was we thought it happens by what is called as cholesterol efflux. Cholesterol efflux is as simple as that you say you're a vacuum cleaner. Okay, then who is a vacuum cleaner? The so-called HDL. Remember, when we are doing cholesterol profile, we mention about 2 things, the bad cholesterol and the good cholesterol. The bad cholesterol goes and sticks to the arteries and causes atherosclerosis. The good cholesterol, which I call is just like a vacuum pump, will go and suck out that bad cholesterol. So essentially, you need what's called as a high-density lipoprotein cholesterol efflux. So we saw, does that do that? And how will we understand? Does it really work in everybody? That we did what is called as the genetic profiling. So in yellow 2, we did not randomize. We knew the high-dose statin of what is called as rosuvastatin work. So we gave it again in patients with obstructive lesions for 8 to 12 weeks. And what we found, that the cholesterol efflux definitely improved, and the change in what is called as the plaque was related to cholesterol efflux. And of course, everybody talks about what is called as a high reactive protein, that also decreased. But more important is these changes were related particularly to certain genetic profile of a individual. So that was something we found for the first time. And here at that time, which was in 2019, we used AI model, okay, and to understand based on certain genes at the baseline, can we predict that this particular person will respond to statin or that particular person needs some other therapy. So we definitely found a model, and in that model we saw certain baseline gene, 18 genes, they were responsible to predict that yes, this person can respond to statin or not respond to statin. Based on that, we went to yellow 3, very, very complex. We don't like to do simple things. Very complex study. Patients were on statin. They came back, but at this time we did patients with obstructive lesion. We had to make sure patient had lipid, because when you are giving treatment, you have to make sure that there is lipid. Many times they do have disease, but they are usually calcified disease, and then the statin or any therapy don't work. Once they had lipid, then these patients were enrolled, and in that enrollment, what did we do? A new drug came, which everybody knows is an injection, which is called as avelumab or PCSK9. It's an injection. It is given twice a month, every 15 days. So we gave that. This time, we increased the therapy for 26 weeks. When they came back, we just did the imaging to understand what happened to the lesion. Very important, we studied what is called as their RNA sequencing. It's a little bit of to understand what genes are at the baseline and follow-up. So if you see here, just look at how the change in total cholesterol and the bad cholesterol significantly decreased when they came back for follow-up. There was no change in high reactive protein, sensitive protein, very important, because we know that high sensitive protein decrease happens by statin. The mechanism of action for avelumab does not happen at that level. Then we wanted to see what changes happen in the imaging. So two things. We did optical coherence tomography to understand how does the plaque thicken. Okay, means there has to be a plaque that it has a lining. That lining became thick, which means the plaque became more stable. It improved. You see that? The baseline was 70. It improved when they came back. And same thing also happened when we checked the yellow. So the yellow of the patients went down. If you take the number, 782 became 235, and we call it as the melting butter sign. It looks like a butter which is inside the body that goes down. So that changed when they came back, essentially saying, if you're on statin, you take avelumab, this thing changes. Then we went and individually understood how do everybody respond, or does the change in the therapy of this plaque happen in everybody or no? We found that only 80% of the patient, their fibrous cap increased, and about 76% of the patient, their LCBI improved. So we call them responders. That means these patients, you give therapy, they respond. Then there is a group of patients, which is a 20% of the patient, where no matter you gave the therapy, and look at their LDL, look at that example. The LDL at baseline was 78. When they came back, LDL was 7, but the plaque did not change. So what is happening? Biochemically, things are changing, but inside the body, the plaque is not changing. So it is just not what the biochemical changes are. There is something more to it, and that is where this transcriptomic or the gene changes. So you can then say, maybe there was a difference in the response between the responders, non-responders in their change in the total cholesterol and change in the HDL. Absolutely no difference. Means both of them responded equally to their change in their lipid therapy. And this is the genetic analysis that we do. So what we did was you take what is called as PBMC, your RBCs. They have what is called as nuclei. Then you run through the machine. You understand the total genes. This is the amount of genes that were analyzed. This is the human body contains of 58,000 more. So about 922 upregulated, 571 downregulated. Means this is normal, that happens in everybody's body. So that is what we found. So whenever you see genes, right, there are multiple genes. But the question is, what is gene? Gene is like what we say, way the body works. So you're born with the DNA then gives out a little bit of this, what is called as mRNA, the part of the DNA which is gene. That mRNA goes and does the work. So if a gene is there, the gene can have multiple functions. Then what happens is, God has created pathways. Cholesterol pathway is one, inflammatory pathway is one, functioning of the neutrophil is one. So various pathways. For one pathway will have multiple genes. So you need to then sit and study through various mechanisms. This gene is related to which pathway. And that is where the AI comes into equation, that you put this whole thing, what is called as an engineering pathway, which is already done by other genetic scientists. So we put all these genes, and then it'll give you this pathway is related to that, this pathway is related to this. So now then you then figure out, are this pathway related to this patient that we are dealing with? So when we say upregulated means it is good. So what was good? So you have to know the mitochondria improved in the patients who had a good response. So what is mitochondria? It's a powerhouse. What is ATP? So ATP is the energy that comes out of the mitochondria, which is responsible to do all the changes in the plaque. So people who responded had the genetic changes which helped in mitochondria and protein synthesis, cell response to stress. Remember, we always say stress is responsible for progression of CAD. All that we have seen here. So oxidative phosphorylation also is a very important pathway responsible for the cholesterol, for the plaque stabilization. People who did not respond, or all downregulation, the mitochondrial dysfunction was downregulated. So remember this word, mitochondria, mitochondria, mitochondria. That is, mitochondria has to be functioning. So these people, mitochondria did good. So if you compare fibrous cap responders and non-responders, about 88 patients responded, 22 patients did not respond. What was the difference? That responders had a good change in the mitochondria, non-responders, no change in mitochondria. And other thing was inflammatory pathways were upregulated, which is not good. That is why they did not respond. Now the question comes is, why did that happen? That is next thing that we have to do. So mitochondrial disease, inflammation are the key difference between these two groups. So when you're going out from here, if anybody asks you what you know about yellow 3, you got to remember that a responder had a good response to mitochondria and decrease in inflammation. Then comes, where did you use AI? This is exactly where we use machine learning. So AI has various terms. It is either artificial intelligence called or augmented. It's mostly machine learning, or it is what is called as deep learning. So we use the model to look at the genes that are listed in the right side. We put all those. These are the genes that we found. If you have these kind of baseline genes, there are 39 important baseline genes which are responsible for inflammation, wound healing, mitochondrial function. They were the one that predicted that this person is going to respond to the treatment. So this is a very important finding, that this we got 38 genes. That is for fibrous cap. The lipid was another 71 baseline genes that we found. So essentially, yellow 3 is that we say they have good mitochondrial function, which led to plaque stabilization. Now, by doing this, what will we do the future? So yellow 4, we are going to be doing. So we know fibrous cap and LCBI responds to certain treatment. Now we know which genetic profile are the one that is going to respond. So we will use them as biomarkers and then develop what is called as a personalized approach. So AI-directed personalized approach for treating coronary artery disease. So that is yellow 3. Moving on to the next topic, which is interesting, which is called as SOFIA. So going to what is SOFIA, I think Beth already mentioned that we want our nurses come back and take care of our patient. Like she mentioned, 30%, 40%, more of the time they are doing charting or on the phone call giving directions and all that. If you talk to the nurses, they always say, this is not what I want to do, I want to be with the patients. So if this kind of mundane work can be done by somebody else, can we get the nurses back to us to take care of the patient? Can we get the nurses to be in the room, help us do the procedure? So it is called an agentic AI, and I'll explain what is an agentic AI, to what is called as a complex clinical workflow, because cath lab workflow is very complex. So we did not take something simple. Call, give me an appointment at 10 a.m. That is not what we are doing. We are talking complex, things. So all this we had shown. If you see, Mount Sinai cath lab volume, over 16,000 procedures, okay? And if you see here, that many patients need to be called and some instruction have to be given. Logistical information, clinical information, a lot of information to be given to the patient. Approximately 15 minutes per patient, or maybe more. A lot of the nurses who are making phone calls are sitting there. I can see them. So look at this. This is Nelia, 2 to 3 phones at one time, trying to take care of everything. And despite that, right, look at how many questions to be answered, and all this happens. So there's no transcript. It is just Nelia spoke to the patient, and it is just written, in the epic, oh, we spoke and we gave. So there's nothing, there's no audio recording, he and she, whatever happened. Now that is why we said, can we use the AI technology to improve the clinical care exactly to do the routine, mundane task? And like I think Beth already showed, patient come out, because what we are also finding is this mundane task is giving them little stress and burnout. But what is the challenge? We already have seen, because everybody is worried. Most important is that accuracy, data privacy, okay? Because, somebody is talking to a patient and all these things. But resistant to adoption, main reason is they are worried the trust in that agent. Two is job displacement. And ethics, that there's no human-to-human touch, okay? So all this can come out. So safe, efficient, patient-centric AI clinical practice, it's what we wanted. And this is something over and over, I keep saying that if you are ready, you're evaluating any kind of a AI solution, a healthcare profession, whether it's a physician, a nurse, has to be part of it. Means you got to be part of developing that particular solution. So you know that what is called as trust as well as empathy, everything is included. Okay, so you know that that's what the patient also wants, right? That is why we all became a healthcare professional. So you want to make sure what you think is the right has to be part of it. So we created Sophia. So look at Sophia. I say 2030, she will be the USA pageant, beauty pageant. Beautiful Indian face with a what? With a Spanish name, okay? For the obvious reasons, everybody hopefully get it.
I am Sophia, a virtual assistant specifically designed to assist patients like you with their cardiac care at Mount Sinai Hospital. My focus is on providing clear, accurate, and helpful information about your procedure, answering your questions, and ensuring you're well prepared.
So what is Sophia's biography? Virtual agent that can do Cath intake calls. You've seen her voice, very soft, calming voice, 24/7, 365 days, no sick calls. Sophia has the patience of an angel, okay? Never gets upset and when she's talking to the patient. And the biggest challenge for her was Mount Sinai Cath Lab. Probably a toughest place to work, but she took her first job there. And we know that something she enjoys, a high internet speed, clear cell reception. It has to be clear, otherwise we'll have issue, and likes to take long walks in the cloud. So what is she may look beautiful, but has strong brains, beautiful, also strong brains. So what happens, what is the meaning of agentic AI? We are going to hear generative AI, agentic AI, a lot of other kind of AI. They are all interchangeable, how the thing happens. So there are various agents inside her brain, but the central AI, which is the Sophia, she orchestrates through various agents. So you have an agent that is validating the patient birth, the date of birth, giving information, where to come, parking. Other one will take clinical questions. Then is frequently asked questions by the patient. What is an angiogram? What is this? What is that? During any of these processes, if the patient's common questions and then goes back, she will hand it over to the previous agent. So that's why the conversation can go very long. You might have heard this word called as hallucination. Hallucination means that particular agent or whoever is talking to you don't know the answer, but they will never say, I don't know. They will just give out some answer that doesn't mean. So by putting important guardrails, guardrail means you train the agent to only answer the question that we have trained. Other than that, you escalate, means she will say, clinical team will call you back with the respective. So if the patient says, oh, you know what, I am coming, but I have my knee pain. Will my knee start hurting? I have a knee infection. She's not going to answer that question. She'll say a clinical person will call back because she's only trained for Cath-related question. After that was done, she had to get credentialing from Mount Sinai. Look at the amount of people watched This is what we are saying. Because AI is coming into the healthcare, there are multiple people wanting it. The biggest one which we also want is to make sure it is compliant, then security, because it is patient questionnaire, so it has to be secure. Then this was the first of the clinical AI that was released in Mount Sinai. So then what happened with that? We had to make sure that the front door policy now has that AI is being used in Mount Sinai when this thing being used. So that's what happens. Then what also happened was that the paper forms committee always wanted something else. The legal wanted that validation has to be very clear. So you will hear what the validation is. So we started the pilot, which was only for patients in the cath lab. Patient is the primary contact, no interpreter. RN reviewed every call. Most of those RNs are here. Grace was champion, and then analyzed by myself, Andrew, Derek. They all are sitting here just to make sure that Sophia is doing the right thing. And then we had a questionnaire that we asked the patient. What is the biggest fear we had? Will patients accept AI agent? So very simple process. Once we know patients are coming for the cath lab, Sophia called them, gave instructions, okay? There's a portal. In the portal, you can see how it is happening. Then we had a criteria. For certain reason, we had to call the patient back, whether it is logistic or for clinical reason. Clinical reasons are very simple. Anticoagulation, diabetic medication, allergies. A nurse or a human has to talk to the patient. After the call, we have a report. The nurse will quickly review. If it's good, it gets into the Epic. In the previous time, legacy, nothing gets in the Epic, one line. Patient was called, information given. Now, look at the conversation. So, nurse can go through this conversation quickly, or they can just go through the highlighted ones. That's what's called as AI call summary. Like here, patient is taking warfarin, blood thinner, and the patient requested, I want to talk to a nurse practitioner. That means you got to tell the nurse practitioner, call the patient back. What was the blood thinner patient took? Was warfarin, very clear, written there. And then there is what is called as orange, which is telling you this needs verification. The nurse did the verification. This is how the report looks like. Procedure detail, service detail, all the questions answered, call summary, and then verification. So these are some of the examples that we are going to do, which is identification, which was the key. The legal would not allow us to use it unless Sophia asked question, and then the person or the patient had to repeat the date of birth and the name back. And guess who is talking?
Hi, I'm the Mount Sinai Hospital's virtual assistant, Sophia. I am calling regarding your procedure with Dr. Kini. I will be recording this call for our clinical team to review and for quality improvement. Am I speaking with Valentine?
Yes.
Great. Before we begin, can you please state your full name?
Dr. Valentin Fuster.
I guess everybody got that. So he very much has approved this and was involved right from the beginning for this project. The second one, which is we've always worry about, is this AI agent empathetic, okay? Is there a human nature in her? And look at this. This call is 29 minutes, 51 seconds, okay? If you see at the top. I don't think any human is going to be talking that long, but listen to her.
Thank you for sharing all of this information. It's clear that has been through a lot, and it's great that she has support from her daughter and you. I'll make sure the clinical team is aware of her history and current situation.
Then also what happens is we do get a lot of patients that are referred to us from tri-state area to do complex procedures. So patients are very anxious and they do have a lot of questions. How this
Yeah, my doctor told me that this procedure would be very difficult for anyone to do because my heart function is very low. What will Dr. Kini do about that?
Thank you for sharing that, Derek. When a patient has a weak heart or low heart function, our team at Mount Sinai is highly experienced in handling such complex cases. Dr. Kini and the team may use specialized equipment to assist or protect your heart during the procedure. For example, they might use a device like the Impella, which is a heart assist device that helps circulate blood during the procedure. This is part of what we call protected PCI, where we use advanced tools to ensure your heart is supported throughout the process. Dr. Kini will carefully review all the details of your condition and procedure to ensure the safest and most effective approach. Let me know if you'd like me to explain anything further.
So, there are more questions related management of calcium, rota, a lot of, because we trained her how to speak when patients ask this kind of complex questions. So this is what we mentioned, that guardrail, in the sense she was trained for cath lab procedures. So what we found, 90 days, nearly 4,000 minutes of SOFIA. That is 2 days, almost 3 days of SOFIA call time, which means if I were not listened, we could have watched over 27 Bollywood movies, okay, instead of doing this. So every second was reviewed, okay, 806 calls, 588 patient had a feedback survey. The oldest patient was 91-year-old, okay, who interacted with SOFIA. So we cannot say it's only young generation, older generation also. So this is the important report card for SOFIA. So if you see our call completion, 86.4%. I mean, even we were surprised that something like this could happen with the first pilot. So 36% we did not have to call the patient back. Everything went very smooth. Then another 1/3 was we had to call back because protocol driven. We said we are going to call the patient back for certain clinical reasons. And there are certain, very rare, if you think, who will say, I don't want to talk to, of the 806 patient, only 39 patients said, I do not want to talk to AI. Boom, they put the phone down. You can't say anything, now you have to get the phone back. The other thing I mentioned to you is hallucinations. So we were worried that there will be a lot of hallucinations, right? Absolutely no, 6%. So technically, anything went wrong was only 6%. 6 patients, only 6 cases of hallucination. That was not bad. So overall, if you see, is that such a great success. And more important is patients, when you'll see what the testimonials are, that for a surprise that everybody liked the agent. So this is overall, every weekly we improved, we were learning. And if you see, our success rate has now reached about 90% once we make the phone call, which is all you see how we get it. This is an important feedback questionnaire that we had, which was IRB approved. So customer satisfaction score, if you see the 10 is green, and anything above 7 is green. So every question that we asked, this was done by an independent person. Look at that, 94.88 is satisfaction score, which is excellent. This is the various words that were used by the patients: comfortable, satisfied, great, excellent. So they actually liked it. So look at some of the testimonials by the patient. I have used fair share of AI services. SOFIA is one of the best. Provided me with a thoughtful response, okay? So not only allowed the prompt, but heard, which was very impressive. You understand? They're saying was very impressive, which that person has used it for many times. This person actually is a lead strategy for one of the, designer watch, Patek Philippe, introduced to a different kind of AI-focused initiative. Nothing I have worked with compares to the well-put-together service. My hats off to the developers. Most AI service would break if that happens. Why? When you keep asking multiple questions, the AI agent usually fails and starts hallucinating. SOFIA did not. She was strong. We made her build strong. Look at this, extensive experience testing technologies just like Mount Sinai's virtual agent. My interaction with SOFIA was seamless. I had no trouble understanding her, and she had no difficulty in understanding me because, accent matters. We have various kind of accent. Clear, concise answer in written. Every hospital should have a system like this. That's what the person says. So conclusion for SOFIA is, performance-wise, ability to reach patient in giving instruction, everything was the best. Trustworthy, right? Low hallucination rate and high quality reliable answer and efficiency. She can handle multiple calls at the same time. Actually, we said Nelia could answer max 3. She can actually handle about 10 to 12 at a given time. And most important, we want to see that she's empathetic, and she was empathetic. Now, do we have challenges? Yes. The biggest is pronunciation, okay, because patients can have various accents. Will she be able to get it? And then interruptibility, because no matter if you keep interrupting, keep re-interrupting, it's like beating her up. We don't know whether she'll tolerate, but so far everything has been good. And one of the most important problem is the speed, because the agent speaks at a certain speed. So for most people it's okay. Some people want it faster, some people want it slower. So now going to what are the future improvements that we can do. We have a long list. So we hope that we will be able to get Sophia into various other areas. That's number one. Use for post-procedure, use long-term patient follow-up, and other one is that we can create a 24/7 line for Cath procedures, where if the patient has any more, okay, we spoke to the patient, they have more questions, they can always keep calling back. And the second is that can the consent process and discharge education be done by Sophia? So we actually presented Sophia on May 12th, which was the birthday of Florence Nightingale, and we all know what Florence Nightingale wanted was that everyone should go to the bedside and take care of the patient. So hopefully now we have Sophia who will take care, means she will do some of the work. So as Florence Nightingale wanted, the nurses could go back and take care of the patient by the bedside. So if you see on the left corner, on the right side you see Mount Sinai Fuster Heart. In the left corner, you see something? Yeah. Do you know what it is? Kini think tank. If you have more questions, you're going to call the AI, which is Anu Intelligence, okay? Thank you for your attention. And now we would like to do what is called as a demonstration of Sophia. So I think we were talking outside, and Mark Dela Cruz, where is he? He said he wanted to test Sophia, number one, and he always Mount Sinai Queens is there, Mark, and Mount Sinai Queens is always our first pilot, right? He has been using STEMI app. STEMI app is doing great under his leadership. He is the nurse manager for Mount Sinai Queens. Come, sit down. So what's going to happen is, Grace is going to, Andrew, you need to discuss the logistics. Come here.
Yeah, sure thing. Thanks, Dr. Kini. So what we're going to do is a live demonstration of the same kind of calls that our patients go through. Mark over here is going to speak to Sophia, press down the button on the microphone because conferences are a little hectic. So she's only going to hear whenever you press that button. Then Grace, just like she normally would, is going to review the call, show you what the portal looks like, the AI summary, and whatnot. And then you'll see exactly what these patients go through. All right?
Have you entered his phone number and everything?
Do you have it pulled up here? Yeah, okay. Let's just make sure that the audio is pulled through.
Let's not, no background noise, please.
It should
Huh?
be okay.
Yeah?
Should
Okay.
be okay to be
She
a
got
little-
used to the cath lab noise.
But just not very much. Okay. Yes. Yes.
Hello. Hello.
Hi, I'm
I'm the Mount Sinai Hospital's virtual assistant, Sophia. I am calling regarding your procedure with Dr. Kini. I will be recording this call for our clinical team to review and for quality improvement. Am I speaking with Mark?
Yes.
Great. Before we begin, can you please state your full name?
Mark De La Cruz.
Thank you, Mark. Now, can you please provide your date of birth?
July 7th, 1970.
Got it. Thank you. Now let's move on to the next part. If you have any questions or need information, feel free to ask.
I'm ready.
Perfect. I have a few important points regarding your cardiac catheterization. Please grab a pen and paper to write down these instructions and let me know when you're ready.
I'm ready.
All right, here are the instructions. 1. Your cardiac catheterization is scheduled with Dr. Kini tomorrow, June 13th. 2. The hospital is located at 1468 Madison Avenue.
Can you repeat that?
Of course. The hospital is located at 1468 Madison Avenue. Let me know if you'd like me to repeat anything else.
Go ahead.
3. Please arrive at the hospital at 6 a.m. 4. When you arrive, take the Guggenheim Pavilion elevators to the 5th floor. 5. Please check in at room 182 on 5th floor. 6. Have someone accompany you to the hospital. If that's not possible, you must arrange for someone to bring you home. 7. Do not eat or drink anything after 2 a.m. on the day of your procedure. Take your morning medications with a glass of water, with the exception of the medications you were asked to stop for the procedure. 8. Bring your medication list or bottles, but leave valuables at home. Let me know if you need me to repeat anything.
Can you repeat the directions again?
Of course. Here are the directions again. The hospital is located at 1468 Madison Avenue. When you arrive, take the Guggenheim Pavilion elevators to the 5th floor. Please check in at room 182 on 5th floor. Let me know if you'd like me to repeat anything else.
No, go ahead.
All right. Now let's move on to a quick medical questionnaire to complete your pre-procedure check. It will only take a minute. Shall we proceed?
Yes.
Great. Let's start with the first question. Do you have any allergies to shellfish, iodine, or IV contrast?
No.
Thank you. Next question. Are you taking any blood thinners like Coumadin, Xarelto, Eliquis, Pradaxa, Savesa, or Lobanox?
I'm taking Coumadin.
Thanks for letting me know. When was your last dose of Coumadin?
I took it 2 days ago.
Thank you. I've noted that. Moving on to the next question. Are you diabetic?
Yes.
Thank you for sharing that. Are you on insulin?
No.
Got it. Thank you. Next question. Are you receiving any continuous medication through a pump?
No.
Thank you. Next question. Are you receiving dialysis?
No.
Thank you. Final question. Do you have fever or chills?
No. But I remembered I had allergies to IV contrast.
Thank you for letting me know. How do you react to IV contrast?
I develop rashes and difficulty breathing.
Got it. Thank you for sharing that. I've noted your reaction to IV contrast, including rashes and difficulty breathing, for the clinical team. They will review this information carefully. Now that we've completed the questionnaire, I'll notify the clinical team about the details you've shared. They may reach out to you if further clarification is needed before your procedure. Do you have any other questions or concerns?
I was referred to Mount Sinai because I have calcified blockages. What will they do to that?
Thank you for sharing that, Mark.
For calcified blockages, your doctor may recommend a procedure called atherectomy or intravascular lithotripsy, IVL, atherectomy. This involves breaking up the hard, calcified blockages into tiny pieces using specialized tools. These pieces are safely eliminated by your body. There are two types of atherectomy technologies, rotational or orbital, both of which are designed to safely treat calcified blockages. Intravascular lithotripsy, IVL. This is a newer technique that uses sound waves to crack the calcium in the arteries. This allows your doctor to safely open the blockages without damaging healthy tissue. Your doctor will decide the best approach based on your specific condition. If you have more questions about this, feel free to ask.
And will I have to stay overnight in the hospital?
In most cases, patients are discharged the same day after a cardiac catheterization if it is safe to do so. However, your doctor may decide it's best for you to stay overnight depending on your condition or the complexity of the procedure. Be prepared for the possibility of staying overnight just in case. If you have any concerns about this, let me know.
No, thank you.
You're welcome, Mark. Thank you for your time and for answering all the questions. If you have any further questions or need assistance, feel free to reach out to the hospital team. Have a great day and best of luck with your procedure tomorrow. Goodbye.
Bye.
It is on, and you can see that it is saying the status running analysis, and now look what the status, like I showed you, orange, needs verification. He said 3 things. He's taking Coumadin, he's diabetic, okay? And also he mentioned he has allergies. So 3 things that the nurse has to review and call back. And the duration was 7 minutes.
So I'm gonna hold this down, and then Grace is gonna walk you through the process of how reviewing this call would work.
So we first log on to the portal, which we're already on. Sophia has already triaged and told me that this patient needs verification. So I'm gonna just click on the report here. You can see the patient's name, MRN, date of birth. And then on the left-hand side, you see the whole transcript of the call. So we already heard the call. I'm not gonna play every text bubble. But on the right-hand side, you also see the AI call summary. So Sophia already told us he's allergic to IV contrast. He's taking Coumadin. The last dose was 2 days ago. He did have some questions regarding calcified blockages. And he also asked about if he was going to stay overnight. Below that, you have the medical questionnaire. So first he said no, he had no allergies, but he corrected himself and said yes. His allergies are IV contrast and that he has rashes and difficulty breathing. He's also on Coumadin. He is a diabetic, but he's not on insulin. He's not taking any, he's not on a continuous medication pump. He's not on dialysis, and he has no fever or chills. So as the clinical nurse just reviewing this call, yes, we want to make sure that he gets a call back. Did he receive any pre-medication regarding his contrast allergy? If he did not get any of that, we have to contact the NP and have that prescribed to him so he can pick it up in his pharmacy. We want to also remind him yes, your last dose was on 2 days ago for Coumadin. Please don't take it on the day of your procedure. And then with diabetes, we want to make sure that he takes his diabetes medication with his meals. If he's on insulin, don't take it on the morning of your procedure, so it could just drop your blood pressure. And then once we verify that, we click up here, we verify it. I would say I agree with this with the patient encounter, called patient to notify him of his medications and confirm allergies. And then I agree with the AI-assisted patient encounter because everything she said was true. Once this is verified, I'm gonna view the report. It shows you what time he's scheduled to arrive, what time he should stop eating. It has all the pre-procedure questionnaire listed down below. And then this shows that I was the one who reviewed the call.
Well, I'm logged in, but yes.
Oh, yes.
I was wondering, when did you become Andrew?
So this
Okay.
report gets uploaded onto the patient's chart in Epic. So this is, instead of the nurse having to manually type anything down, everything was recorded.
All right, thank
Any
you.
Okay.
questions?
Any questions? What?
Can Sophia arrange transportation?
So I'll take that question for the panel. So when Sophia gets a question about needing transportation, that information is relayed to the clinical staff. So when Grace is seeing these calls, she already knows and anticipates what she needs to talk to the patient. And Grace, in your experience, once you know what the patient needs are, what's your callback time like with these patients?
Thank you. So when patients do mention, oh, I need transportation, once we review the call log, we do call them back. We need to make sure their pickup address is correct. We need to make sure their phone number is correct. The driver will call them as they're on the day of the procedure to let them know that they're on the way. And we also need to know whether the patient is in a wheelchair, a walker, or has a cane. So those are all the things that we need to make sure that's correct.
I mean, we gave only, despite it's such a complex clinical flow, certain things we did not, but you know, as this pilot is improving, I think she can take on more jobs. She can take care of that too, yes. Many of these things, this is not Epic integrated. Once it's Epic integrated, we will just say, we know you're diabetic, we are just confirming you're diabetic. Because if you really have, so far not a single patient has ever said that to us. There's so many phone calls that, you know, you already have my records, but why are you asking me the same question?
So that's a good question. Right now, we're only using Sophia for English, and one of the challenges is we don't have a nurse to review the calls in Spanish. So Grace did skip it since he already heard the call, but every one of the utterances that Mark made, you can play back and listen to make sure that the information was captured accurately. And we do require that as part of the workflow, especially for the clinical questions. Are you allergic to IV contrast? We ask them to play, even the no or yes. It just takes a second. And yes, I know no in Spanish is very similar, but for the more complicated questions, we just don't have the staff to do that call reviewing
Okay,
right now.
no, very simple. She'll be talking more languages.
Yes.
You start in English, you perform, you know, you have to perfect one language, and it's very easy to, you know, change.
There's a question there at the top.
So that was one of the challenges, and that she can't discern well if it's the patient speaking or a family member right next to them that's part of the conversation. So she'll just take that in as the same person speaking. So the answer is she is sensitive to background noise. Especially when there's a TV. Yes, playing news very loudly.
Yes.
So that can be variable to whatever the clinical use case is. So for our use case, we call our patients the day before, but it's indefinite.
Going back to your question, because right now, definitely many 30–40% of the patients are being seen by us in the clinic, and we tell them we are booking you, and there's a nurse practitioner talking to them. So as we move forward, as it is booked, there can be automatic you know, message going to them that Sophia is calling, you're booked, and again, you know, discuss the Cath procedure, because now Cath procedure is still discussed by the nurse practitioner who is booking. Like we said, remember I said consent process and all that, so many of these things can go to her, discuss everything, so the nurse practitioner's time spent will be again decreased, so we can use them to many other areas.
There's another question in the middle.
So of those futuristic ones, yes, she'll be making phone calls. Right now, we are not doing the post-discharge phone calls, but yes, that is, we already have ready, but not implemented yet. Post-discharge phone calls, and then, like we said, the follow-up calls, because New York State wants us to call the patients at 30 days, and many of them maybe at 1 year. So, it's also a good practice to remind patients about the medication adherence, go and see your primary care doctor or your cardiologist. So these kind of reminders will be sent for patients after procedure.
Yes.
Okay, so remember the way we have programmed it is like we are not asking the list of medications, and that's probably not the right thing to do. Whenever it comes to a lot of complex clinical and medication, FDA will not approve something like this at this time, okay? So we did not even approach that question to give a list of medication. That's number one. Going back to your questions of allergies, suppose she says I'm allergic to penicillin, right? We are okay, but our biggest concern is that allergy to contrast, because we may have to sometime postpone the procedure. So that is why these guardrails and the clinical questions are already pre-formed. What is it that is important? Otherwise, you're right, they could be allergic to ACE inhibitors, which does not matter to us, but it will be part of the record. But for cath lab procedure as such, it does not matter other than contrast allergies.
Just to echo that, what Dr. Kini said and what Beth was saying, that the focus really is on safety and doing what's clinically appropriate, and particularly with medications that are very sensitive. So collecting the information and having an appropriate healthcare provider contact the patient is the most prudent way to be handling these type of situations.
Any other questions? Okay, good.